We are so thrilled that we're able to do this webinar. People ask us all the time, they call our patient advocates and are asking for information specifically about mistletoe. And what an honor to have one of the leading experts on this webinar for people to learn from, to gain more information, and to hopefully help those that they love with cancer. And you know, more so than a physician, she's been a dear friend of mine. Met Nasha at actually international meeting on mistletoe that was held in Germany in 2014. So it's been several years of really seeing her thrive and shine in so many aspects. So greatly respect her work and all the ways she's helped us. Really, it is her courage to bring the intravenous mistletoe therapy into her practice when she was practicing in Durango at Namaste Health Center that really opened the eyes of us as a group that was actually working on the protocol for the mistletoe clinical trial with Johns Hopkins University School of Medicine. And her successes that she was sharing were just so incredible that it led the researchers to want to actually try it intravenously versus subcutaneously injections. So really, she's definitely a pioneer in the world of mistletoe, and so excited to have her on here. And as Jensen mentioned, I know I'm going to just mention this because it's one of the favorite resources on the Believe Big website. And if you don't have it, make sure you grab a copy of it. The Metabolic Approach of Cancer that she and Jess Kelly wrote. And what I love about this book that's very different than many cancer books that are out there is that I really love that they have a section in the very front to assess your terrain, and it has different aspects of it. And just to give you an idea, they have from genetics to epigenetics to blood sugar balance to my favorite, which was the toxic burden. And they ask you questions on each of those topics and more to really assess yes or no. Does this question apply to you? And you know, some of them really surprised me, like in the toxic burden, do you find it difficult to sweat? I'm like, wow, why is that interesting? That's an interesting question in toxic burden. You know, do you have any known environmental sensitivities such as odors to perfume or diesel fuel? Things that I probably wouldn't have connected with the toxic burden. And so what I love is that once you take this little evaluation, it actually asks you to look and score what is your most yeses in what section. And then it allows you to focus in on that area that is most critical to your particular terrain. So really awesome book for anyone that you know that has cancer, or for your information to prevent cancer as well. So if you also go to drnasha.com, she has this beautiful resource on there that's free, and it is called the 5 Steps to Take After Cancer Diagnosis. It's a guide, and you can just go right to her website and downloads immediately. It's a great resource if you hear the words you have cancer. Great first steps to really breathe and to really evaluate things before rushing into treatment. So I really love that guide that she put up there. Also, after tonight, we will send you some links that we will discuss here. So we can send those to you in the email. Since you are registered, you'll get a follow-up email. Thank you for joining, but also with the links to some of these resources. And one of them is actually the Believe Big Frequently Asked Questions about Mistletoe. It's one of our many resources on our website, believebig.org, that you can go on and download and share with a friend. So really excited to start this. And so let's get going. I'm going to actually ask Nasha some questions that people have been asking me, and then we're going to let her talk through those things. And then at the end, there's a section on your screen, if you look, to ask questions. And then I'll be monitoring those throughout the evening. And then I can go ahead and ask her with the time remaining that we have left on the webinar. So make sure to chime in with your questions as they come up. All right, so Nasha, why don't we go ahead and start with the beginning? So can you briefly share with us about mistletoe and the history of it in regards to treating cancer?
Absolutely. And first of all, thank you again for that little intro as well. And I really appreciate that you brought to everyone's attention that what we're talking about from the book is also for people that don't have cancer. I mean, we've talked about that the only real cure for cancer is prevention. And so I really want this information out there so we can avoid being 1 in 2 men and 1 in 2.4 women in the United States expected to have cancer in their lifetime, that we can avoid to be one of the 1,600 people a day that succumb to this disease in this country, and to avoid being a doubling of our cancer statistics by the year 2030. So even though our discussion tonight is more solution-based with regards to a therapy that's coming upon its 100th birthday, perhaps in the future we can have, and I believe we do have coming up, some that are a bit more of why are we here? How did we get here? So I just appreciate you kind of planting that seed for everyone to be considering as we're having this conversation, because we won't spend the time into the why. We want to spend the time into the what, and where do we go from here at this point. So ultimately, this plant totally intrigues me. And if you've just taken a walk in nature anywhere that there is a tree, you have likely stumbled upon what a mistletoe plant looks like. At this point, what we know of the history is beyond its sort of rich, ancient, druidic, mythologic, and even folklore-centric remedies. It was used in sort of fertility, and it was used in sort of the concept in some of the ancient mythologic writings of bringing back the dead from the underworld, and has this very interesting kind of mythology around it as well. But we've been using it successfully since Hippocrates' time, the father of medicine, as a spleen tonic. And in Chinese medicine, that's related to our digestion and absorption of nutrients and the dissemination of those nutrients throughout the body. But in Western physiology and anatomy, the spleen is very much involved in our rebuilding and recuperation and regeneration of healthy new blood cells, and specifically into stem cells and immune cells. So it's pretty cool that we had a sense of that back at the time of Hippocrates, way back when. And gosh, about 100 years ago, just over that time, a woman named Dr. Ida Wegman and an anthroposophical philosophic man by the name of Rudolf Steiner. Many people know him from the realm of biodynamic farming, permaculture, maybe Waldorf school training. He's also pretty famous for his work with architecture, but he also had a keen hand in the natural products world, and especially into natural therapies. And he and Ida Wegman in the early 1900s started to use this therapy as a cancer therapy. And you can go into more of the details on the Anthroposophical Physicians, American Physicians website, which we'll also have links to this evening as well, to read a bit more about this. But basically, this therapy, which I'll go into a little bit more detail in a moment, is getting ready to celebrate its 100th year. Next fall, September 2018, there'll be several huge events happening all over Europe with regards to this medicine and its ongoing continuous use as an injectable adjuvant therapy in cancer. It is the most studied integrative cancer therapy in the world. If you have been diagnosed with cancer and you live in Europe, especially if you live in places like France, Switzerland, Austria, and Germany, you have about an 85% chance of having this therapy woven into your therapy, into your treatment for cancer somewhere along the way. And if you live in the rest of Europe, you have around a 65% chance of that therapy showing up at your doorstep to support you through this process somewhere along the way. That's so shocking to me that it's almost unheard of in this country. And yet there's a growing number of studies of uses of this plant medicine in Southeast Asia, in South America. In fact, one of our colleagues who's presented often at the Mistletoe conferences is the head of one of the largest hospitals in Sao Paulo, Brazil, and uses this therapy as a treatment in pediatric cancers. So that should show you kind of the safety and efficacy. If we're willing to inject this into our little people, during a cancerous process, there's probably something to it, okay? So hold on to that thought as we're moving through here. And then just again to reiterate, you know, in Europe and around the world, this therapy is not necessarily thought of as a standalone therapy. Okay, so both Evie, Lisa, and I will talk a little bit more about this into our conversation this evening, but it's been utilized as an adjuvant in addition to standard of care. So right alongside your surgery, your chemotherapy, your radiation, your targeted therapies, your hormone blocking therapies, your immune therapies. Okay, so it's not an either or. To me, this medicine is such the perfect bridge of our time and where we're wanting to go with integrative oncology today. So I think that that was a mouthful. I'll take a breath and see if there's anything else you want me to allude to before I dive a little bit more into this incredible plant.
Yeah, no, I think that's amazing. And it's so true, because when people hear about it, they're concerned, you know, when they're not fully 100% aware of it like we are and have been educated on it, they assume that it's either or. Okay, I either do mistletoe or I do my traditional treatment. So what would you, you know, before we go there, what would you encourage patients to, you know, who want to, you know, investigate mistletoe and want to bring it to their oncologist, but they're concerned of the backlash or them not treating them? Or what do you say to patients who have that concern and how to overcome that?
Sure. Well, first of all, there are, again, on your website, there's a lot of good resources, and your question, most often asked questions, is on there. But you can simply do a PubMed search yourself. If you type in mistletoe, you're often led down a few different rabbit holes. But if you type in its Latin name, Biscum album extract, that might get you a little bit closer to some good, reputable resources and studies. In fact, there's about 250 studies that we would consider prime, good quality studies per FDA standard US research models, okay? There are also thousands, and I mean that, thousands of studies worldwide on the application of this medicine in a variety of ways. So just again, I want to kind of tease in a few places where it's historically been used. It's been used with epilepsy, hypertension, headaches, menopausal symptoms, infertility, arthritis, rheumatisms. That's all right there on the NCI, National Cancer Institute, sort of repertory of information about natural substances. There's over 3,000 species of this plant worldwide. You, like I said, probably stumbled upon it yourself in nature. One of the things I think is very interesting is that even though we have 3,000 species, we have three main categories. We've got the European mistletoe, we've got the American mistletoe, and we've got the Korean mistletoe. We've done studies on all, but interesting to me is that the European mistletoe seems to have, and we'll go into mechanism of action here soon, the build out, the structure that has the most efficacy specific to our oncology world. Okay, and it makes me think about, again, when we think about plant medicines in general, it's like it's growing in a part of the world that is rich. It's from the area known as the Black Forest in Europe, and you think about the rich constituents of that soil and the ancient history of that area, and the terroir, the soil itself, is what gives rise to the types of chemical aspects of where these plants grow and where we can harvest and cultivate them further. So I think that's pretty interesting. Another interesting piece before we move forward is how in the world did somebody like Rudolf Steiner and Ida Wegman stumble upon this? They were simply out in nature, and they were keen observers of nature, which is also how we practiced medicine since the beginning of time. You know, the ancient Vedas, which is the oldest medical, the Chaka Samhita, the most ancient medical text there is, was written by the Vedas, the Ayurvedic doctors, which then gave birth a few thousand years later to Chinese medicine, which then gave birth down the road to vitalistic medicine, homeopathy, osteopathy. And so the common theme of these vitalistic medical programs was a keen observation of nature and what's around us in nature. So for instance, when Rudolf Steiner noted this semi-parasitic plant that blooms in the winter. That's why you see those little berries that we hang over doorstops that we can make out under, which is completely out of the rhythm of the host tree, which has gone dormant and cold, hibernated for the winter. And it also grows towards its own center, and it never touches the ground. This reminded him of a cancerous process, that utter loss of rhythm and connection to the natural flow and process of the body. In fact, in anthroposophical medicine, cancer itself is often considered a disease of complete loss of our rhythm, of our pattern. And it's no wonder living on the planet today with lots of unnatural circumstances around us that we've lost our way, that we've lost that rhythm, and our cells have lost their rhythm and their connection and communication to the outside world. And so I just thought that was a pretty interesting concept to look at here. And when you look at this plant, if you just simply took the plant and crushed it up and ate it, or took it as a tincture, it has a very different personality, and in fact, a toxicity that's not recommended. We don't recommend you run out and take this in an oral tincture because it's actually quite toxic. And yet again, this group of observant doctors and philosophers realized if you took some of the berries from the winter and some of the leaves from the summer, and you basically macerated it and whirled it together in a particular rhythm that moves in one direction on one side and the other direction on the other, creating this concept of a torus, which basically we'll get into, I won't go into physics here, but basically it's a very potentizing aspect in a lot of things in nature and a lot of things in medicine. They ended up with this extract that became incredibly potent medicine. And once it's sterilized and in some forms maybe fermented, in other forms maybe filtered, we found different sort of behaviors and different outcomes with the use of these plants. So just to give the listeners an idea, there are over 36 different companies processing mistletoe in Europe, in the EU, okay? And the 3 or 4 that we might have heard of, that you might have heard of across time, might have been Iscador, Lectinor, Helixor, Viscosan. Currently in the United States, the only one we have access to is Viscosan, which is the exact same product as Helixor, just relabeled in this country. But basically, each of them vary a little bit by the way they were manufactured, by the way they were harvested, by the way they were distilled or fermented or filtered. And so each of them have a little bit of a different characteristic, and therefore a different sort of affiliation with a particular tumor type or condition of the patient. So I want that to be known, because I think sometimes we think it's a one size fits all and that everyone gets the same dose and the same potency and the same form. And yet there are many varieties to this. And there's a time and a place when you've had some expertise, which we hope to bring on some of the thought leaders of this and do a 3-day intensive in June, which Jensen talked about, and you'll see again at the end of our presentation to dive deeper into this. But you've got to realize that this plant, when it's been used rightfully with the right group of patients at the right time, specific to their gender, their condition, their tumor type, their staging, their types of other therapies they're bringing on board, this therapy can be very effective as a subcutaneous injection, an intravenous injection, in many parts of the world, an intratumoral, peritoneal, or pleural injection, meaning into the abdominal cavity or into the lung cavity or directly into a tumor itself. And so even what we see and do here in the United States is just a fraction of what we're doing abroad. So I wanted to make sure I rounded out a little bit richer history and different uses and applications and even different names that may elude a lot of people here in our country, because we are a bit limited in what we have access to and the way we can apply it in this country.
Yes, that is so, thank you for sharing that, because it's so important. It's so important because a lot of people hear mistletoe, or they've heard my story or other stories, and they're searching for mistletoe. And unlike a supplement, you really have to be, really has to be prescribed by a physician who has been trained in it. Because as you said, I love that it's very individualized. It's based on your cancer type, it's based on your gender, it's based on where you are in your cancer journey. and what your body responds to. And you really need someone who is very familiar with mistletoe. And if you, right now, if you go onto believeBig.org, there is, if you look under resources, there's a tab, drop down menu that says find mistletoe physician. And so we vetted several physicians throughout the country that are trained in mistletoe, that we know have been trained on mistletoe. So it's really, really important that people on this call know that it's not something you just go to the vitamin shop or get online and I'm going to start taking it. It really has to be prescribed by someone, a naturopathic physician, a DO, or an MD who knows mistletoe. So thank you for sharing that. Which brings me to the question that I get asked all the time is it effective for all cancers? I know that there is some variance in information when it comes specifically to brain cancer. I've been told in the past that it doesn't cross the blood-brain barrier, and so it's good for quality of life, but may not be effective for tumor progression. So can you touch on that, or what types of cancers you found it to be most effective in, or what types of cancers you used to prescribe or that physicians actually prescribe it for?
Such a good question. And you're right, there's a lot of misinformation, confusion, and definitely some nuances that just take time as an experienced provider with this medicine. But basically, a quick brief breakdown is you can get a lot of varieties of what trees the medicines grow on. But what we mostly are familiar with, at least in the West, is the apple, which is the the mallee series, the fir, which is the abies, and the pine, the pinus, P-I-N-I-S series. Also in some of the forms like Iscador, you might have run across the Q, which comes from the oak, or the Fraxini, which comes from the ash. But both of those are actually considered subtypes of the apple, of the mallee. So these are just some nuances that if you're running across, if you happen to be on one that says, I'm taking an A series, you'll know what I'm talking about here. And these are based on tumor types and genders and tissue types and levels of strength in the organism of the host, or the body, the person who's dealing with cancer. So that's something to keep in mind. So basically, when I talked about the different forms that you'll find, what we get access mostly to here in the United States is the Viscosan, and we'll typically see the M, the A, or the P series that will be used for this. Specifically, for instance, when you asked about the tumor types, where I have personally seen the biggest impact of this. Now, this might differ from my colleagues' experience, so please know this is just one practitioner speaking to their own experience with this. Is I've seen it to have best outcomes in patients with any pelvic, genital, urinary, gastric-based cancers. So basically anything along stomach, colorectal, rectal cancer, anal cancer, anything in the pelvic girdle of especially ovarian, uterine, cervical nature. Okay, so I've seen really beautiful responses in that. And I've also seen really powerful responses in a lot of the immunogenic type of cancers. So when I say that, what I mean are like things like squamous cell cancers, whether they're in the lung or the cervix or the rectum, or whether we've seen a cancer that's related, like renal cell carcinomas are very immunogenic, as are bladder, meaning they've got a lot of issues around dysregulated immune function. And then also in the blood cancers, lymphomas, leukemias, melanomas, and multiple myelomas seem to have really good outcomes. Now, I will tell you this, I have used it in every cancer type since, and even the weirdest, squirreliest, most rare forms with good response. Okay, and so that's important to keep in mind, that does not negate you if you've got pancreatic or primary liver cancer or even brain cancer. So let's talk about that for a moment, because I was trained in Iscador at first. Okay, when I was trained in the use of Iscador, I was told it was an absolute contraindication for brain cancers. The reason being is because of the level of viscotoxin in the Iscador form, which is just one of the chemical constituents of this, that can have the potential of creating swelling before it moves things in the right direction. So basically anything that can take up space, what we call a space occupying lesion that has the potential to swell, like something in a biliary tract or in a lung space, like bronchial, or in brain, the idea that something could swell 40 to 70% more than its original mass for a short period of time could be dangerous in certain situations. And the nature of viscotoxins create a little bit more of that inflammatory cytokine release initially. But in forms like Helixor, in fact, when I first gave my very first presentation to doctors, I shared with the Helixor team and a whole room of doctors that this was an absolute contraindication with brain cancer. And the Helixor people basically raised their hand and said, that is not true at all. In fact, in the Helixor realm, which is the viscosand form, it actually is utilized quite regularly with brain cancers and does not have that same space occupying lesion concern that we have with the Iscador form. So I thought that was quite interesting. In fact, there is a couple of trials worldwide on the use of this with GBMs, glioblastomas, and there's one that we're hoping to get going at a major university in the United States in the not so distant future, specific to this brain cancer population. With regards to it crossing the blood-brain barrier, if you remember at the beginning of our conversation, it has a history of being used in some neurological issues such as epilepsy and headaches. And so I think that there is some evidence that definitely crosses the blood-brain barrier in a unique and safe way. But again, this is the place where you want to work with, when in doubt, work with a seasoned, trained professional who knows what type to match with what condition at any given time.
Thank you. That's really informative. And so my other question is, so there's the subcutaneous use, and then there's also the intravenous use. So there's benefits to both, you know, and so what do you determine is the difference in recommending the intravenous versus the subcutaneous mistletoe therapy?
Perfect. Well, the first time I was exposed to mistletoe therapy in this country was in 2003. And up until 2014, so for 11 years, that is the only form I had access to, knew anything about, applied to myself, applied to others, was in a subcutaneous form. And as far as I knew, that was all there was. Okay. And it wasn't until the big aha moment where you and I met in 2014 that I realized this could be used in a variety of ways beyond the subcutaneous way. So that being said, I had just as good of outcomes with the subcutaneous approach as I did when I started implementing intravenous approaches. But when I started to understand and learn at the conferences and colleagues who've been teaching me this along the way, was that the IV application can be very, very effective in folks in more like a palliative state, very much like end of life care. It can be very, very helpful with extreme tumor burden that needs a little bit of a bigger pushback at a given time, especially if someone's condition is rapidly failing. So in fact, one of my very first experiences with IV mistletoe was for someone who was not responding to opiates any longer in hospice, literally days from crossing over, you know, from launching out of their physical form. And I went over because the hospice team requested. I actually had some good relationships with hospice in my community and did a lot of home health support for folks in the end with acupuncture, homeopathy, and other therapies for many years. But we were able to administer IV, very, very low dose, just 150 milligrams of intravenous mistletoe. And this person literally was in a kind of a coma-like state, opened their eyes, the flesh came back to their cheeks. They actually asked for food and water. And that was in September 2014, and that person is still alive today. Wow. Now, let me just say that is not likely a normal response, okay? There was one of those moments of, did that just happen? I mean, it was sort of like we all sort of saw a ghost, okay? So that was just one of those extreme stories. I like to share the extremes because miracles happen. Thanks to people like Kelly Turner and her work, we see that these happen maybe a lot more often than we're led to believe. But that was one extreme example. However, I've also had patients who've come in who were literally carried into the clinic. In fact, some that we've had mutually shared folks that were carried in, unable to walk under their own volition, under so much pain, and under so much medication that kept them in such a fog that literally in the midst of the several hours of the infusion, the lights sort of came back on, their energy got better, they kind of kicked in, their appetite kicked in, and their pain diminished in the midst of their very, very first IV. That is not as uncommon as you would expect. And in fact, the most dangerous side effect of that is people withdrawing from their opiates too quickly, okay? Because suddenly they don't think they need them, and that is not a good idea. Again, you want to be in a very clinical environment. You want to work with a team that knows how to support you with the other therapies you might have going on, but it's not uncommon to see immediate pain reduction. It's not uncommon to see immediate sort of vitality seep back into the client in front of you with an IV application. So there are times and places, if you're in a place where you have no access to an IV and you're in trouble, by all means still use the sub-Q. One does not necessarily preclude the other. They just can be used at different times. And the other mistake I see made is people might do IV, but then forget to do their sub-Q. And as Elise mentioned, they offer a little bit different mechanisms of action and rapidity of their onset of symptom support. So a quick breakdown of just general mechanism of action for mistletoe in all of its infusions. Why you don't hear me talk about its oral use, even though it has an accepted labeling for oral use for headaches, even in this country, we don't use it in cancer orally. It frankly doesn't work. And the reason being is because the main constituents of the anti-cancer effects of mistletoe are called lectins. These are particular chemical structures within the plant that makes it have the cancer fighting qualities. It is degraded too quickly in our GI tract, in our saliva, in our tube, in our stomach, in our small and large intestine. So we have to avoid that by going subcutaneous, intravenous, intratumoral, peritoneal, or pleural. So those are the ways. And in some populations, we've seen in some pediatric populations, maybe nebulized has a role, but we won't go into that here today. So I'm going to kind of look at my list here so I don't miss anything on its main mechanism of action. But the immunogenic activity, meaning the way it helps support and modulate the immune system, is related to a variety of biologically active components, including the lectins that I've discussed, but also the viscotoxins, amino acids, flavonoids, triterpenes, alkaloids, and polysaccharides. Now, if you're a cancer researcher, your little ears should be buzzing right now, because that's where we're putting all of our research dollars and the billions of dollars we're infusing into immune therapy research right now. It's all about lectins, folks. It's all about these particular proteins. It's all about these polysaccharides. And yet we've had access to this type of plant medicine for some time without the side effects that we're seeing with some of these billion-dollar drugs that are hitting the market. Mistletoe lectins, which are the most abundant and most studied compound within the mistletoe, have some cytotoxic activity, meaning they directly can kill the cancer cells, and immunogenic properties. Whereas the viscotoxins and the alkaloids, along with a few lectins that I've already mentioned, can actually have a direct kill to the cancer cell by inducing apoptosis. That's a really big deal, because if we're inducing apoptosis, that also insinuates that we're upregulating mitochondrial function, which is what is in charge of apoptosis, programmed cell death. And cancers start to grow crazily because they don't have that programmed cell death or apoptosis working properly. So mistletoe has been shown in a variety of its compounds to impact that one major component of a cancering process, which I think is huge to really highlight. It also lowers angiogenesis, which is the new growth of tumor, of blood vessels to the tumor, by lowering something called vasoendothelial growth factor. We give pharmaceuticals for that. They have a lot of terrible side effects. This works quite well. It stabilizes the DNA and repair of healthy DNA in our healthy cells. It inhibits ribosomes and protein synthesis, which is related to the inhibition of cancer cell proliferation. So it actually stops the cancer cells from proliferating further. It impacts platelet aggregation and inhibits metastasis. So when cells get really thick and sticky, they have a tendency to invade and metastasize more. So it helps kind of keep things nice and fluid and moving around the building nicely, but not invading and migrating and metastasizing. Very anti-inflammatory. That's one of the things we can easily see on lab values, but also subjectively from patients' pain response. By modulating the pain response, lowering things like interleukin 6. This is huge in cancer research because C-reactive protein and IL-6 are also prognostic in cancer progression. It immunomodulates, as we mentioned already, by stimulating macrophages, T lymphocytes, natural killer cells, dendritic cells, cytokines. Again, if you are an immunologist or a cancer researcher, you are pretty excited to hear these kind of words because this is a big deal. It acts like a fever-inducing therapy similar to things like Coley's toxins, which you can go and Google and learn about, interleukin 2 therapy, and even a lot of the immune therapies we're putting out on the market today. It stimulates the marrow, very similar to Neupogen, Neulasta, which are very toxic and oxidatively stressful, inducing medications. And yet this medication of the mistletoe can help keep the blood counts to a point where you can easily get through your conventional therapies without injecting a $10,000 shot into your body and creating even more problems down the road. It's well known to enhance overall quality of life, including mental well-being and lifting of the fatigue that goes along with this diagnosis and treatment. Again, we've talked about its different ways of being administered, but overall, there's even a study that came out in 2001 by Keen, a bunch of the German researchers, that showed that it can actually increase survival rate over 40% in colorectal cancers, anal cancers, breast carcinomas, non-small lung carcinomas, and stomach cancers. That is pretty juicy. And I know I'm not even hitting on all of them, but I wanted to make sure that the listeners got an idea that we didn't just pull these concepts out of nowhere. These are well organized, and the only studies I'm speaking to here are the ones that we would even consider good studies, good quality studies in this country. And the few studies that are a little bit confusing were frankly just poorly designed models, because it is an individual treatment guided by the individual response for the individual at the time of their diagnosis, the tumor type, the patient constitution, the gender, etc. And it's very hard to create the proper study that goes with that approach of research.
Wow. Wow.
Big wow. Sorry about that. Everyone's like,
it's amazing. It's amazing. I'm thankful for scientists and researchers like you that know all this information. And yeah, I've always heard, basically that the IV is 7 times stronger, as you said, that it can push back someone who's in the later stages. And the subcutaneous, is good for all, of course. I always like to mention too, and in sharing my story, and I tell people, is that it's just one piece of the puzzle. People always say, well, just give me some mistletoe and I'll be fine. And it's almost like I tell people that, you can go to the gym every single day and then you can go eat at McDonald's at night and you'll never lose the weight. So mistletoe is a large piece of the puzzle, but it's just one piece of the puzzle. And I want to make sure to make that clear. It's not the magic bullet. As Nasha was talking about, and also in her book, your terrain, there's so many aspects to it. And I think that's why cancer, it's so different than any other disease, in that there is a emotional component, there's a physical component, there's a relational component. There's so many stages and types of cancer that you really have to have it individualized. And that's what I love about mistletoe, is that it can support so many aspects of that. And so I really wanted to share that. People always say, well, so what did you do? And I was stage 4, and I combined the best of both worlds. I did have conventional surgery of my colon and my liver. And 2 weeks prior to my liver surgery, I started on the injections of mistletoe. At that time, I didn't know about the IV application. It wasn't even available here in the United States. But I added that, and my husband did a lot of research on supplementation and diet. We had the help of my anthroposophical physician, Dr. Hindenburger, and worked really amazingly with my oncologist, which is also very important to have this team of physicians that are going to work together to help you heal is so vital. And so, thank you for mentioning all those aspects. And so, one other question that I think is really important to ask you as the physician, a lot of times people will say, well, will it counteract my treatment if it's an immune booster? What the doctors are trying to do is to suppress it so that then the chemotherapy can be effective. So if it has that immuno boosting effect, then how does it not counteract treatment? And also, are there any side effects to it? You see people, you say is actually a response you want, the fever, or the isolated injection site area that shows a redness, that it's actually working for you, the specific dosage. So how do you respond to actually the side effects for the IV versus the subcutaneous?
Okay, well, you're right. We actually do want to have a little bit of something. It's known as a cytokine release. It should be local. It should be at the injection site. For subcutaneous, we might have something different with the IV, which I'll go into in a moment, but the subcutaneous should be at the moment of injection at a 45-degree angle in the subcutaneous level, which is important because that's where we access the B cells of our immune system, which send off all the signaling to the rest of the cells in the body and activate everything to do its job. So that being said, it should be a little bit red, raised, itchy, maybe a little burning at the site. It shouldn't be larger than, say, $0.50, and it shouldn't spike your fever above 100.4 degrees Fahrenheit. If it's overzealously stimulated into a higher fever or a higher redder spot, or the reaction lingers for more than 2 to 3 days, then you might want to take a little break, stop it for a couple days, and then dose down. Take a much lower dose, maybe a 50% reduction, and start slow. This is a simple, like, again, your body is the guide here. And interesting, you might have different responses at different times. You might be going along for a couple weeks and have barely anything, just a little tiny hint of red, and then suddenly get a big whammo. Sometimes that's because your body might be fighting off another infection, or it might have had, just like maybe you're finally waking up that dormant immune system. But one of the things I think is very important for the listeners to understand is we used to think this was an immunostimulator. But I use the languaging very carefully. It's an immunomodulator. So very quick visual. I do this a lot, but here's the teeter-totter of your immune system. This is very, very simplistic, okay? So on one end of the teeter-totter, we have Th2 dominance. This is where we often see cancer processes. Allergies. So people with a long history of allergies have a higher risk of cancer. So if you had allergies as a kid, you get in there and you clean up that terrain now so I don't see you as a cancer patient down the road, okay? That's a Th2 dominant process. A Th1 dominant process at the other end of the teeter-totter is an autoimmune reaction, okay? That's our rheumatoid arthritis, our lupus, our Hashimoto's, okay? This end of the teeter-totter is also no bueno. That's where you're always very scared of stimulating an immune reaction. And in fact, our new beautiful billion-dollar immune therapy drugs are literally killing people from autoimmune organ failure side effects, okay? It's overly shutting down Th2 and overly stimulating Th1. So where we want to focus in cancer care in general is we don't want to guess. We want to be very judicious in our approach. We want to focus on the center of that teeter-totter. We want to modulate. We want to balance it, okay? So when we use things like getting your vitamin D levels appropriated, making sure your microbiome is functioning, vitamin A status, things like that are very helpful. Probiotics, fish oil, very much work on the center of this teeter-totter, okay? Very simple, inexpensive things many of us just do every day, right? But low-dose naltrexone, things like immune therapies, and especially things like mistletoe, have a direct impact on the center of this teeter-totter. So whether you are Th1 dominant, Th2 dominant, Th1 and 2 dominant, which is a fun journey I had in all of this, or both Th1 and 2 depleted, we can balance that right here. And so it is used to enhance outcomes with whatever therapy you are adding it to, whether it's standard of care chemo, radiation, surgery, immunotherapies, hormone blocking therapies, targeted therapies, or even IV vitamin C, hyperbaric oxygen, ketogenic diets, CBD therapies, you name it. We are able to come in and support that overzealous or underzealous response to get what we want for an outcome.
That's awesome. That's awesome.
Yeah.
That's a great way to explain it. And so I see we have about 10 minutes left. I know it went so fast. I was like, wow, so much great information. I learned so much already. I thought I knew so much about this. but I continue to learn by hearing from you and others. So thank you for all that you've shared tonight. And so I'm going to go ahead and open it up for questions. And if you guys look at the bottom tab of your screen, there's a Q&A box, and you can open that up and you can ask some questions. And while those are coming through, I just wanted to give people have been asking also about the Mistletoe clinical trial. And so I just wanted to give you just a briefing about what it is and where you can get more information about it. I can't share results or anything like that because it is still in process. And so Johns Hopkins will release that information once things are completed. But I wanted to let you know that in December of 2015, the phase 1 intravenous mistletoe clinical trial was approved by the FDA. And that was just an exciting night. And what was amazing was that it was actually approved on Christmas Eve. I mean, mistletoe, Christmas Eve, approved on that day. It was just incredible. And it was a long review process by them and also the Johns Hopkins Internal Review Board. I really feel like this is a huge step forward because it brings the best of the conventional world and the complementary world together. It's a team approach. It's been a team approach. And the reason why this trial is so important, because until a clinical trial is completed here in the US, mistletoe cannot be offered as standard of care by oncologists. As much as they may believe in it or know its validity, until a clinical trial is done here on our soil and shown to be safe and effective and gone through the process, they will not be able to cover it. And our hope is that one day it would also be able to be covered by insurance. So that's the reason why we're doing this trial. And thank you for all of those of you who have supported that initiative, part of Believe Big, and continue to support it through this process. And so I wanted to let you know that the primary objective of the trial is to test safety and to identify the recommended phase 2 dosing. Patient eligibility requires that a patient be a solid tumor patient, stage 4, that at least one line of prior systemic therapy or other standard of treatment had been done, and have a life expectancy of greater than 3 months. There's more specific qualifications, and you can go on believebig.org. There is a What is Mistletoe tab on the top, and there's a drop-down menu that says mistletoe or the clinical trial, and you can click in there and it'll actually take you to the government website that tells you the specifics on what you need to do in order to inquire about participating in the trial. Okay, so I see many questions that have come through, and so I'm going to go ahead and start here at the top here for the people who chimed in first. And so the question is, a patient with cancer was considering mistletoe, but was confused when hearing about the immune response and the inflammatory reaction we described as a desired effect. Wouldn't causing inflammation be a bad thing?
So hopefully I explained very clearly and that teeter-totter analogy. And then also it's a local inflammatory response that just is basically stimulating a communication system in the rest of the body, an abscopal effect, meaning a distant effect from a local response.
Okay. This next question says, is the lectin in mistletoe, are they the same lectins in legumes?
Yeah.
Okay, very good.
There's lectins in everything. So the lectins are very individualized to different things. So again, we're not putting lectins through a GI tract. We're not doing that because these get degraded. We're doing this through a vascular, subcutaneous, intratumoral thing, which is bypassing. When we think about lectin issues and GI, inflammation or allergies, they're a whole different animal that we're talking about here. Yeah. Okay. Good question.
Awesome. Yeah, I didn't know that. So what, someone's asking about when you're doing other treatments, when would you do it on the same day, on the off day, for when you're doing the IV mistletoe or the subcutaneous? Does it matter when you are doing that in conjunction with it?
I love that question. I should have said this because you could literally shoot up your mistletoe and go onto the surgical table. You could literally be getting an IV of mistletoe while getting, just finishing up your chemotherapy or just coming out of your radiation. The only thing you don't want to do is you don't want to inject into surgical sites or radiation fields or anything that looks irritated and obnoxious. And you don't want to re-inject if everything's still reacting strongly from the previous injection. Otherwise, there's literally literally no contraindications of when this is applied in the midst of therapy. And I have a lot of patients that'll do their injection and go in for their chemotherapy or go in for their radiation. Not a problem on the same day or even within a few minutes of treatment. Yeah.
Okay. Yeah. And so, thank you. And so what do you suggest for those who are in remission or have a past chemo or radiation exposure? How does mistletoe fit into their journey going forward?
It is such a huge part. When I do the trainings for the physicians, I spend probably an hour on this alone, maybe 30 minutes on this alone. So I can't go into it here because it's very individualized for the tumor type and the person, the constitution and their history and how much treatment they had, et cetera. If there was someone who had a massive stage 4 aggressive cancer type that likes to recur very rapidly, such as ovarian cancer, for instance, if it recurs within 6 months, that's considered, unfortunately, a death sentence in Western medicine. I'm going to be a lot more aggressive with them in staying on it every week for the first 2 years. Because once we hit the 2-year mark with ovarian cancer without a recurrence, your likelihood of recurring drops over 70%. But there are certain types like breast cancers that don't really like to recur for 5, 10, 15 years. So I look at more of like a long-term sort of maybe a few times a year treatment. Maybe we stay on it for the first full year out of therapy and then maybe start to spread out the treatments and maybe do a box or 2 a year for ongoing maintenance. So it'll differ on tumor type, personality, because there's also no issue of getting on it and staying on it. Okay, I have a lot of patients who will think I don't ever want to inject for any longer than I have to, but they'll get to the end of their 6 months or year, their 2 years and say, can I keep going? Yes, you can. There's no problem continuing on this therapy as well. And I think you and I can both attest to that personally, as well as hundreds of other patients that have made that same decision.
Yes, and that's actually, was one of the next questions. And, I get asked that a question a lot, and I always defer to the patient's physician. But for me personally, especially with my history with Lynch syndrome and just the positive effects of it versus the negative side of, say, even the cost, which is for me $150 a month, which is nothing to me when I'm looking at my health, how it improves my immune function and my outlook and so many other aspects besides the keeping my immune system strong to prevent a recurrence. But I'm here 10 years out and I still do my mistletoe injections. I do it in a maintenance version and I'm still getting a reaction, which they say is important. I've had to increase over the years, but been told by my physician who prescribed it that it's really a personal decision as to, it's that whole side of that emotional, physical connection that, having something that supports your immune system, but it supports you emotionally as well, and your outlook and life is really, really important. And so, that was a great question that you answered. And it's a question that a lot of physicians were even discussing in Germany. How long?
Exactly.
No pat answer for it, but yeah, I really feel it's an individualized decision. But I don't think I'll ever stop. Yeah. All right, so this next question is, okay, that's a little more specific. Okay.
Yeah, it's tough to get to the specifics without seeing the whole terrain, the whole constitution. So it's kind of dangerous and unethical, actually, for us to answer anything really individualized. Yeah.
Yes. So I'm kind of looking through here.
I'm hoping we've covered a lot of people's questions. Are you saying?
Yes.
Not
we
good.
Really good. And so I'm looking here. Okay, so, and I guess is another personal question, but when you're looking at a later stage diagnosis, and this is what this person was asking, they're stage 4, as I was, and, have been told by physicians that, chemotherapy was a must for them, and that, the chances of survival are so much less if you don't. And so how do you balance that as a physician, but also as a patient when you're hearing this information to process through what's best for you?
Wow, that's such a beautiful question. And I guess I'm going to kind of throw a question / comment back out to everyone and just chew on this for a moment. But if I ever ended up back in that cancering place again, and I opted to do standard of care interventions of any kind, whether they're in tiny microdosings or full kablam, full napalming of the system, would it not make sense that you would bring on a supportive therapy to help the outcomes of those therapies to, as I stated earlier, a 2001 study showing a 40% survival rate compared to people not on, or a 40% higher survival rate compared to people not on mistletoe, compared to all the different things I was explaining, that it can help keep your blood counts good through therapy, that can help keep your quality of life and your energy and your stamina and your fatigue at bay, through the process. It would make sense to me that if you're looking at down the barrel of the gun and trying to decide which way to go, if you go that, whatever route you choose, this therapy is a way to enhance your outcomes no matter how aggressive the treatment or how aggressive the cancer. So it's sort of a comment question back at you place that it seems really strange to me that we don't just automatically fit the same bill of 85% of people in vast majority parts of Europe taking this along with their conventional standard of care therapy.
Yeah, but this person in particular, I believe, did not want to do the conventional. And
I hear you.
That they needed to, and so they're feeling this fearful state of, what if I don't listen and I go down the wrong road? But I feel like I just want to do the mistletoe, or I just want, which was my case. But again, my terrain, my situation is completely different than someone else.
Well, and I think you nailed it. First of all, you need to look at a lot more than whatever therapy you choose to do, whether all conventional, no conventional, all alternative, no alternative. You have to understand what's best for your constitution by understanding how you got there, which requires the ability to test, assess, address, and adjust accordingly. We don't guess. So I've had folks who spent tens of thousands, hundreds of thousands of dollars on alternative therapies who never took a conventional standard of care therapy, who had failed them miserably because, I'll tell you quite frankly, it was the wrong treatment for them. It was not appropriate to their constitution, their tumor type, their reason why they got cancer to begin with. It's both ends of the spectrum. I've seen malplaced treatment decisions because we jump into reaction versus response and deep learning and understanding of our constitution before you do anything. That's why I give that 5 handout that you're going to be sharing. Before you choose anything, see what's actually going on with you, and then choose. And if you do choose any therapy, conventional or otherwise, or a combination, make sure it fits you. We are in a time in our world today, you do not have to guess. You can be truly precise about and target your cancer from a variety of ways. Purely standard of care, purely alternative, and everything in between. So that would be my recommendation to that person is, don't just go, go and get quiet and get clear with yourself, but explore what got you here and explore what's going to help get you out of here before you jump on whatever treatments you choose. But I do recommend that some type of supportive therapy along the way, be it emotional, dietary, lifestyle, spiritual work along the way, including some things like mistletoe, can at least cushion you while you're determining the best next steps.
That is phenomenal. Wow, fantastic. I'm going to just ask you one last question because I know we're out of time and I want to respect your time. There was a question that, I know it doesn't counteract treatment, but this person was asking their CA-125 rose 60 points since they began sub-Q mistletoe and the keto diet within the last month. Could the rise be the mistletoe, and can it come back down, or is it something else that she's not aware of?
Well, again, I need to look at the whole terrain, but there are many chemos, especially in the ovarian cancer realm, that will rise your CA-125 initially, especially doxorubicin, Gemzar. That's a very common finding. So there are many chemos that will take your CA-125 up before it comes down, or other tumor markers for that matter. So 1 month is nothing. You want to look at the rest of it. I would look at the trifecta. I would look at other labs. I would look at other things going on into the system. Are you actually doing a proper coached ketogenic diet, or are you doing Atkins, or what I call junk food internet keto? Are you doing a high meat keto? Are you doing, have you let go of all your veggies? There's so many components to this of how to answer that question. So please work with an integrative provider that can really assess your terrain for you, and also recognize that in the first initiation of a lot of therapies, especially therapies that have cytotoxic nature, you will see things swell and lyse. So there's actually a concept called tumor lysis. So go and take a look at what that looks like, which we'll see some markers go up before they come down. So there's a lot of ways to answer that question, but it depends really on that individual, and I would encourage them to follow up, do with their due diligence on that. Yeah.
Awesome. Well, thank you so much for your time. Amazing. I'm so excited for this webinar. And for those of you who are here listening, because you registered, you will get the actual link following this webinar, so you can kind of watch it over again if you missed something or you're taking notes and you're like, wait, I didn't catch that quite well. So we will make sure that you have that replay link. And then also we will post this in the future on our website for people to learn more about mistletoe. But thank you so much, Nasha, for your time, for all the work that you do to help the cancer patients in this country. And I'm just so thankful for you. So
you all the best, and back at you. Thank you so much, everybody. Have a beautiful, beautiful night. Thank you.